the cycle continues. And the primary objective of this series is to share knowledge, to give the society the seed of knowledge. The best gift we can give to the society, the gift of knowledge. And the wisdom is the best asset for an individual. So thank you, Dr. Lakshmi, to start this program a year ago, more than a year ago, and to continue and again to come to a conclusion. I hope we'll start another program in a different name, and it will again continue to contribute to our knowledge part of reproductive medicine or reproductive biology. Now, important aspect is that this particular program is unique in one way, that it is being involving more than a dozen of societies. This is very important. The way we progress is the networking. More you make a network, your net worth of the society improves. And that is a very important way of enhancing our ability to contribute to the society. Now, I have only two important points for you. One is the important point is that our society is growing, but we need to have a better growth rate, even much better than our GDP. Our GDP is going somewhere 6, 7. So we should have at least double-digit growth rate of the society. So I request you honestly to make your friends, your colleagues, your trainees to be a member of the society. Bring them to the webinar, any program, even without any registration. Get them, get involved. Initial, the spread of knowledge is very important to enhance our ability as a society. Second important aspect is we just completed the second part of the national conference, that is our second Jua Isopar in Jharsuguda, which is an excellent program. In fact, an excellent combination of the program. I will not go to the details of that, but I will invite you to another program, the National Annual ISOPAP Conference in Vijayawada. Please come to the program, join us, bring your colleagues, your friends, your family, and your friends, and inspire them to contribute their free paper session. This is a part, very important part for the NMC, for postgraduate to appear in the postgraduate examination. Please encourage them, bring them. And at the end, I wish, pray that our program today and tomorrow, and days to come, will achieve the grand success to contribute to the knowledge base of the society. Thank you. Thank you very much.
Thank you, sir. Thank you so much.
Thank you, sir. Now, Sahiti, please share the CV of Dr. Pragya Mishra. So now may I request our very dynamic Secretary General, Dr. Pragya Mishra Chaudhary, who is the consultant in fertility specialist at New Life Test Tube Baby Center and MGM Hospital Research Center, Patna. She is Secretary General of ISOPAP since 22 to 24. Chairperson Genetic and Fetal Medicine Committee, FOXY 2016-18, Founder Secretary of Bihar Chapter of ISHAG, and many other activities. Vice President Patna OBGYN Society, she had been. Then Secretary Patna, she has actually held all the posts, and now she's going to take over as the President of Patna OBGYN Society. She is also the proud awardee of Healthcare Professional of the Year from the Bihar Gynecologist Award, George Mahoney Award, C.L. Jhaveri Award, Dr. J. Mishra Gold Medal Award, MP John Award, and has contributed so many 10 books, chapters in 10 books and papers in national journals, organizing secretary of FOXY ISPAT, GFM Con, organizing secretary of 24th Boxcon, and many, many other conferences. So over to you, Pragyati, for to address the gathering. Over to you.
Yeah. Good evening to all the people, the faculty and the delegates who have joined in for today's webinar. First of all, Supriya, you don't have to trouble yourself so much in reading our awards over and over again. I think a few lines.
Yeah.
So actually, memories go back to 2 years ago when I took over as the Secretary General of ISOPAB, and a few new committees. Earlier, ISOPAB had only one committee, which was the quiz committee. And in my tenure, this Fertility Enhancement Committee, Rural Committee, and Family Welfare Committee all came up. And we had a good time really deciding how to name the committees. And that was when, Dr. Lakshmi Shikhande's name was recommended for a Fertility Enhancement Committee, and she and I together decided that it should be called Fertility Enhancement Committee. Now, another reason was that people think that ISOPAB is only perinatology, but it is reproductive biology also. So that's how, the Fertility Enhancement Committee was born. So, and what I have seen that consistently this committee has been doing very good work for the last 2 years, and they have been quite consistent in their programs also. Almost every 2 months we are having one new. And Dr. Shrikhande, is it 2 months? 3 months? I'm just
Every alternate month.
every
Every
2 months.
alternate month.
Yeah. So, I mean, it's like a good example for other committees also. That how the way you have been working, and Supriya has been doing the groundwork for you. So together you'll have, and the best part, and I think I have mentioned in previous webinars that you are bringing international
Yes.
people who are doing infertility to us, so that we get the advantage of listening to them. So we have international faculty as well as national faculty, both. So I know that this is the end of 2 years for you, and we will see after we've had one executive committee meeting, we will see what needs to be done next. So since this is the 10th one and the last one for this year, I would congratulate you for really bringing this committee, not only bringing, first of all, you have given a name for this committee, you have given a platform for this committee, and have been committee has been going higher and higher with every passing month. So really congratulations to you, and all the then chief guest for today's occasion, Dr. Manju Gita Mishra, Dr. S.N. Tripathi, guest of honor, Dr. Sulekha Pandey, present president of ISOPAB, without whose support we cannot do anything. So Dr. Narayan Jana, and past president Dr. Gangadhar Sahu, whose vision of ISOPAB is something which is just exemplary, I would say. So today again, you have involved, so many chapters. So we would get the advantage of listening to so many people, and your talks you have already mentioned in your speech regarding your talk, and talk by our esteemed speaker from Bangladesh. So I think let us all together join hands in um, uh, keeping up the flag of ISOPAB, and raising it higher day by day. And since, this small thing I would just like to bring in, because so many chapter secretaries and presidents have logged in, I would just like to remind them that a small, I would say, a small favor for ISOPAB which you could do is it's not just a favor, it's according to the bylaws that every society with more than 100 members has to give an annual subscription of of 10,000 rupees, and people with less than 100 members about 5,000 rupees. So it's just a few. Dr. Sulekha Pandey handed over the check to me, and I think a few recently, like Delhi chapter. But I think we have so many chapters, almost 42, 43 chapters. So that really needs to come from your end. So I would be grateful for that. So, and thank you so much for making me a part of today's webinar. And not only today, but even in the past, you have done so. And since in my special interest is in infertility, so I gain a lot from your webinars. So thank you so much, Dr. Kande and team. Thank you so
Thank you, Pragya. Thank you so much, because you were always there for all kind of support and guidance. So thank you from bottom of my heart.
much. Thank you.
Thank you, Pragya Di. Your very, very extempore speech always is wonderful, and you cover every detail, and you also updated people that they should follow the norms of ISOPAB. So thank you very much for a wonderful speech. So now I move over to our guest of our chief guest, Madam Dr. S.N. Tripathi. Madam has sent her apologies because she had a parallel commitment somewhere, so she won't be able to join. And the second chief guest is Dr. Manju Geeta Mishra, Madam, who's the backbone, or the what you can say. Madam is the strong pillar of support for this ISOPAB. So Madam has been past president of many societies like IMA Bihar chapter, All India Doctors Wing, and many others. ISOPAB, of course, in 2014-16. Madam is recipient of many, many awards and Lifetime Achievement Awards. She has delivered numerous orations, guest lectures in state, national, and international conferences. Madam had been a great contributor of such chapters in Foxy Publications, and edited Critical Care in Obstetrics and First and Second Edition, Treatment and Progress in Obstetrics and Gynecology. Madam has more than 70 publications in various national and international journals. Moreover, Madam is teacher of teachers and a very, very popular ISOPABian. So, Madam, over to you for your words of blessings.
Very good evening to all of you. Thank you, Dr. Supriya, for your kind words. First of all, I must congratulate Dr. Lakshmi Srikhande for organizing regularly this Fertility Enhancement Committee of National ISOPAB, the Seed to Bloom series. And I think this is the 10th episode. So, respected President of ISOPAB, Dr. Narayan Jana, Secretary General ISOPAB, Dr. Pragya Mishra Chaudhary, past President Dr. S.N. Tripathi, President-elect Dr. Sulekha Pandey, and Chairperson of this Fertility Enhancements Committee, Dr. Lakshmi Srikhande, and co-convener Dr. Supriya Jaswal. First of all, I must thank you for making me the part of this webinar, and I think regularly this series is conducting various episodes in at least every month or so on, and I have been the part of I think all the episodes. So I must congratulate Dr. Lakshmi Srikhande, because this is the first time that this committee has been formed, and Lakshmi Srikhande has been made the chairperson of this Fertility Enhancements Committee. And regularly she is organizing this Seed to Bloom series. And I think in previous episodes also, she has involved the international speaker. And this time she has involved the international speaker from
Bangladesh.
Bangladesh. So I must congratulate you and thank you, Dr. Lakshmi Srikhande, for regularly organizing this type of webinar, and you are taking so much interest in this activity. So, and I think all the chapters and all the members of ISOPAB have been benefited by this Bloom to this this webinar which you are conducting regularly, and I think this time the topic is PCOS and infertility. This is very important topic because the incidence of PCOS has increased in the society, and we are seeing the large number of young girls. They are visiting us for PCOS, and ultimately they land up with infertility. So the topic which you have selected are the PCOS and infertility, and second topic, that is luteal phase support in ART. So both the topics are very important and interesting, and I think all the members will be benefited by these topics. So once again, I thank you for making me part of this webinar and involving me. And the topics which you have selected is very important, especially for the infertility, for the infertility and for our members also. So our members will be benefited by this webinar. So thank you very much, Dr. Lakshmi Srikhande, for making me this part of this webinar. Thank you very much.
Thank you. Thank you so much, madam. In all the episodes, we always had one international faculty. So that, I mean, there is exchange of ideas, what they are doing at their place and what we are doing in India. And in every episode, we involved as many chapters as we can. So that was the standard format of this committee. So thank you so much, madam, for gracing this webinar and blessing us. Thank you.
Thank you, madam. Thank you. Your words of blessing really matter for each one of us. Thank you so much. So, the guest of honor we have, as we are really fortunate to have the president-elect ISOPAB, Dr. Sulekha Pandey, madam, as the guest of honor, and she is professor and ex-head, Department of OBGY, Institute of Medical Sciences, BHU, Varanasi. Madam had been the ex-professor and head, UCMS, Nepal, presently director, Srishti Fertility Clinic, consultant Apex Super Specialty Hospital, and vice president, National ISOPAB in 21-22. Madam now has been the president-elect, National ISOPAB 23. So awarded Best Student Award, Vice President of India, Silver Medal and Pfizer Gold Medals, recipient of INSA Fellowship and visited Germany, Fellowship in Maternal Fetal Medicine in Hanover Medical School, Germany. Madam has many accolades to her credit and published more than 70 papers in national and international journals, examined in more than 15 Indian universities, and Madam had been awarded Manishi Ratna 2008 and Kashi Ratna 2010. So huge number of awards, madam, to your credit. And thank you for accepting to be the guest of honor. Over to you, madam, for your words of blessings.
Thank you very much, Dr. Supriya.
Okay.
Good evening to all the present and the past members, and also the present president, past president, and all those members who are present. My special pranam and namaskar to all of them and all the senior members who are present in this episode, including Dr. Manju Gita Mishra. Thank you very much. It gives me immense pleasure to join in the last episode of Fertility Enhancement Committee of National ISOPAB in association with Vijayawada, Patna, Raipur, Kolkata, and Vidarbha city chapters, organized by the most dynamic lady whom I know for more than 30 years, Dr. Lakshmi Srikhande, and all the chairpersons. And also I thank Dr. Pragya Mishra, who is very dynamically conducting all the activities of ISOPAB. My special thanks to Dr. Supriya Jaiswal very nicely she has conducted 9 episodes of this uh, um, fertility enhancement webinars. My sincere congratulations to all the participants who took part in the series of webinars, and I wish that such webinars should continue in the future so that all the members of Isopar family are up to date in all the aspects of perinatology and reproductive biology. This is not the last episode, as Dr. Lakshmi said. I think this is the beginning of the first episode. So please continue.
Yes,
And
madam.
it was very nicely organized by you. And I'm sure all our present, past, presidents, secretaries, and all the chapters will join hand with you to continue these type of episodes. So without wasting much time, I would like to thank the international speaker and all the speakers who were participated and who are going to participate in these sort of webinars. And we all encourage these webinars because everyone can sit at home and get knowledge about all the recent advances that are taking place. Thank you very much once again, Dr. Lakshmi, Dr. Supriya, for inviting me in this last episode of Fertility Enhancement Committee of National ISOPAR. Thank you.
Thank you, madam. Thank you so much.
Thank you, madam. So with this, we come to the end of this inaugural session and we start with the scientific session. So the first session, we have the keynote address. One sec. So it is the luteal phase support in ART by the speaker, none other than Dr. Marufa Khanam, madam. And we have to chair the session. We have Dr. Ram Prasad De, sir, who is Editor-in-Chief, Indian Journal of Perinatology and Reproductive Biology. He has been the National Vice President-elect ISOPAP to 26-27, National Corresponding Editor Jogi, and Vice President ISOPAP at Kolkata. Foxy Mr. Chandravati Devi and Jagannath Singh Prize. He is the recipient of so many awards. Sir has had special interest in so many publications, more than 45 publications. So welcome you, sir.
Thank you. Thank you.
Thank you.
Thank you.
And the next chairperson is Dr. Zareen Rahman. She is senior consultant in ex-HOD, ex-deputy director, Koji Holy Family Hospital, Patna, and MRCOG Part 3 clinical examiner. She is being the fellow representative RCOG East Zone, vice president Patna chapter of perinatology, Patna PAB, working committee member of Patna Menopause Society, and she is also the member of breast committee chairperson, Patna OBGY Society. She also a DNB teacher and guide for 15 years. So welcome, Dr. Zareen. And over to the chairpersons. Sorry, the next chairperson is Dr. Jyoti Jaiswal. Has she joined, madam? Have you joined?
Jyoti,
I didn't
yeah.
see.
Yes, ma'am.
Yeah, you are there. Okay.
Jyoti is
So,
here.
Dr. Jyoti Jaiswal, she is also a very dynamic ISOPARBian who's conducted such a wonderful conference at Raipur, professor and HOD Department of OBGY, but JNM Medical College, Raipur. She has got so many positions: National Treasurer, Vice President, Professor and Head, Secretary General, Raipur ISOPAR, Treasurer, Chhattisgarh IG, organized so many conferences, published so many books, and she is the proud recipient of so many awards: Foxy UNICEF Vishesh Appreciation Award, Foxy Achiever Award, NICA Award, and so many. So welcome you, Dr. Jyoti.
Vinita.
And Dr. Vinita Kumar Sinha. She is the youngest one of the lot, Associate Professor at Department of OBGY and MCH Patna, Co-Chairperson International Academic Exchange Committee of POGS, that is Patna Obstetrics Society, Clinical Secretary Patna PAB, and Jagdishri Mishra Award. She is the recipient of Jagdishri Mishra Award, contributed so many chapters in books and publications, special interest in high-risk pregnancy. So thank you, Vinita, for joining. Thank you all the
Thank you,
chairpersons for coming.
Supriya.
Thanks for the opportunity.
Over to the chairpersons. May I request?
Yes.
Chair-
Hello.
Yes,
Yeah,
sir.
we can
Yes.
hear you, Dr. Day.
Kindly,
Yeah.
Am I audible? Yes.
Yes,
yes, sir.
yes.
Yes, sir.
Yes. Good evening, everybody. Respected today's all the dignitaries, particularly the President, Professor Jana, President-elect Sulekha Madam, immediate past President, and also our guest of honor today, Manju Gita Mishra, and also the past President, Dr. Gangadhar Rao. It is my privilege and honor to be here with us and sharing the chairs. I was also previously attended this series of program, and for this I must thanks and congratulated Dr. Lakshmi Madam as well as Supriya for conducting a beautiful this CME. And today we are fortunate enough to have with us in international faculty Dr. Marufa Khanum Parag Madam. Dr. Marufa Khanum Parag Madam is going to talk on luteal phase support in ART patient. This is not only important for the ART patient, this is also important for the general practitioners also, not on the fertility patient. Madam is from the Bangladesh, and he is also the professor and HOD Department of Obstetrics and Gynecology of the Health Institute of the Chatang Medical College in Chattogram. And he also so many awards and also the so many publications. He is the fertility specialist, and he is the first test tube baby center in Chattogram in 2013. The first test tube was born in Chattogram in 2014. She has several research works in the reputed journal, executive member of Fertility and Sterility Society of Bangladesh, the live member of so many society of ISAR and IFS. They invited as a panelist and chairperson of various fertility program across the country as well as across the globe, presented so many papers. So may I invite Dr. Marufa Mabars to start the session. Madam, floor is yours. Madam is going to talk on this luteal phase support in ART. Yes, madam. Madam, yes, please.
Thank you. Can you hear me, sir?
Yeah.
Yes,
Yeah.
yes. And
Yes,
we can see all the slide also.
Yeah.
Yes.
Slide share also, it is.
Yeah, we can see.
Yes, it is. You can see.
I want to talk with luteal phase support in ART. Respected chairpersons, chief guest of honor. I am Professor Dr. Mafruha Khanum, getting from Chattogram Port City, Bangladesh. Seed to Bloom series, episode 10. Thanks to Indian Society of Perinatology and Reproductive Biology for giving me the opportunity to present my topic, luteal phase support in ART heart. Dear learned participant, good evening. Welcome all of you to my presentation. Luteal phase support in ART. Getting over our confusion, what is luteal phase? Luteal phase of menstrual cycle starts after ovulation and leads to formation of corpus luteum, which produces progesterone as a major hormone. Luteal phase lasting between 12 to 14 days. We all know the progesterone after establishment of pregnancy, the corpus luteum is rescued by the luteotrophic effect of HCG, which is produced by implanting embryo. HCG supports production of progesterone from HL by regulating gene expression. The progesterone produced from CL is essential for maintenance of early pregnancy until placental function is established. Luteal phase defect. What is luteal phase defect? Luteal phase defect is defined as luteal phase length of less or equal to 10 days. And LPD is a condition in which endogenous hormone production from ovaries is not in enough quantity or for length duration. So clinical LPD is defined as luteal phase length is less or equal to 10 days. LPD has not proven yet as an independent cause of infertility or recurrent pregnancy loss. Luteal phase has controversial topic with doubts regarding its clinical evidence and relevance due to lack of reliable diagnostic criteria and treatment options. Characteristics of luteal phase deficiency. Low progesterone level, delayed endometrial secretory transformation, shortened luteal phase of less than 10 days, ultimate reduced embryo implantation, lower pregnancy rate, increased miscarriage rate. Incidence and prevalence. The incidence of LPD is between 6.6 and 51, estimated by the endometrial biopsy in normal fertile women. Endometrial biopsy timed during luteal phase and analyzed according to the criteria remains the gold standard for many years. In normo-ovulatory primary or secondary infertile patients, in prevalence is 8.1%. In women with recurrent miscarriage, it will be 32.5%. Pathophysiology of luteal phase defect in natural cycles. Abnormal follicular phase leading to lower levels of progesterone and estrogen. It's altered FSH-LH ratio and FSH and LH pulsatility. And endometrial resistance to progesterone as for where the cases PCOS, endometriosis, we see the endometrial resistance. So abnormal luteal phase. So the abnormal luteal phase, there are many factors associated in luteal phase defect in natural cycles also. That are those short menstrual cycle, unexplained infertility, endometriosis, thyroid and protein disorder, obesity, hyperandrogenism, so many causes. Pathophysiology of luteal phase defect in controlled ovarian stimulation cycles. Multifollicular development during controlled ovarian stimulation, supraphysiological levels of steroid, negative feedback effect on hypothalamus and pituitary axis. It inhibits luteinizing hormone release, luteolysis, and LPD. So, supraphysiological levels of steroid causes early secretory changes and granulostromal dysgeunia and impaired endometrial receptivity, ultimate luteal phase defect. So, luteal phase defect due to supraphysiologic steroid level in controlled ovarian stimulation. Why is luteal phase defect in ART cycles? The luteal phase defect is an unavoidable consequences in all ART cycles. ART cycles include where IVF, in vitro fertilization, intracytoplasmic sperm injection, frozen embryo transfer cycle. This patient receives embryo either following controlled ovarian stimulation or an anovulative cycle. In both these situations, LPD is an inevitable consequences. This association is of LPD in women receiving controlled ovarian stimulation in ART cycles is well recognized. Multiple explanations have been proposed to possible cause of LPD in women with ART treatment. Suggestive theory, which are the theories of LPD in ART cycles. LPD may be the consequences due to loss of granulosa cell, which variably aspirated during oocyte retrieval. And DNRase antagonist, which does not cause long-term suppression, it may cause premature luteolysis with poor pregnancy rate without progesterone support. And administration of HCG for ovulation triggering has been implicated as a possible cause of LPD, though suppression of endogenous LH in early luteal phase. And also LPD may cause due to prolonged suppression effect of long DNRase downregulation. And this suppression effect may continue to inhibit LH release in the luteal phase, thereby affecting corpus luteum for production of progesterone. And multiple factors like inhibition of LH release, premature luteolysis, and defective progesterone secretion. What is luteal gap? Between the stimulatory effect of exogenous HCG used for triggering ovulation and endogenous HCG originating from the conceptus. During this luteal gap, that endogenous progesterone production may drop, therefore causing harm to the potentially developing embryo. Concept of luteal phase support. Endometrial receptivity is driven by the time of progesterone exposure after the adequate E2 exposure is crucial for the trophoblast endometrial interaction. LPS is important in preventing luteal insufficiency and its negative impact on early pregnancy. The successful outcome of early pregnancy depends on progesterone, corpus luteum, first 7 weeks of pregnancy, trophoblast after 9 weeks. During luteal placental shift, progesterone is secreted different ratios from both sources. Drugs and protocol for luteal support. So, undoubtedly, progesterone is the drug of choice for luteal support in ART cycles. Progesterone guideline is ovarian stimulation for IVF and ICSI guidelines has recommended progesterone for LPS in IVF and ICSI cycle. Cochrane Systemic Review 2015 has established the beneficial effect of progesterone on live birth and pregnancy rates in IVF cycles irrespective of routes. Why progesterone is important? Preparation of endometrium for implantation, that means secretory changes, decrease contractility of uterine smooth muscle. And this is the uterine contraction and induce secretory changes in endometrium. It improves the endometrial receptivity, stabilize lysosomal membrane, which leads to quiescent uterus, leads to uterine relaxation by blocking chemokines, has immune modulatory effect and prevents the conceptus from the rejection along with HCG and cortisol. Regulates natural killer cell and HLA genes. Which will be the routes of progesterone preparation for LPS? Progesterone preparation for LPS, we know there is the synthetic progesterone and natural progesterone. Here the natural progesterone, parenteral, oral, transdermic, and vaginal. Parenteral routes oil-based and aqueous-based is IM and also subcutaneous, and oral route poor bioavailability and poor permeability in transdermal and also vaginal. And there is synthetic progesterone, dydrogesterone. Well documented evidence of intramuscular and vaginal progesterone in luteal phase is an ART GnRS A agonist and antagonist cycles. Estre guideline follows the ovarian stimulation for IVF and ICSI. 2019 guidelines recommends the use of any of the above mentioned routes except the oral for natural progesterone as LPS. Or vaginal route of natural progesterone administration yields better results than oral micronized form of natural progesterone due to less viability of oral progesterone. Vaginal progesterone. It reaches maximum serum level 3 to 8 hours after the application. Greatest advantage of vaginal progesterone is first pass uterine effect. It gives a local effect before entering into the systemic circulation, in which the endometrial concentration will be much greater than what is expected with other forms of administration. This is the vaginal progesterone, first uterine effect after 1 hour. This is also after 4 hours. And oral progesterone, its maximum serum level 2 to 4 hours, and RCT users of oral micronized progesterone had a significant decreased implantation rate. Vaginal progesterone versus dydrogesterone. The recent established data confirmed that the efficacy of daily 30 milligram of dydrogesterone compared to daily 600 milligram micronized vaginal progesterone as LPS. It is well tolerated and efficacious, may replace micronized vaginal progesterone as the standard of care owing to its patient-friendly oral route. Dydrogesterone may include a paradigm shift in the treatment of IVF. Oral progesterone guideline. According to 2019 Estre guideline for ovarian stimulation in IVF and ICSI cycles, dydrogesterone is probably recommended for luteal support, and compared to other progesterone, dydrogesterone has similar ongoing pregnancy, similar safety and tolerability, and better patient compliance. Oral dydrogesterone, better and convenient option, where approved in threatened and recurrent miscarriage and other progesterone deficiencies, greater viability, minimize the activation of receptors than the progesterone receptor, and thus minimize the unwanted effects. And it shifts the cytokine balance from T helper cells and induces the nitric oxide synthesis that improves the endometrial receptivity and pregnancy outcome. Suppression of T cells and killer cells activity. There are so many activities, and this is better and convenient option. Bioavailability, progesterone has 5 to 6 times better oral bioavailability than the oral progesterone. So 28% oral dydrogesterone, where the less than 5% oral progesterone, that is, this is natural, and 4 to 8% vaginal progesterone. But Australian and New Zealand guidelines, dydrogesterone is the best option for the luteal phase support in women undergoing ART treatment. Exogenous progesterone is associated with significantly higher pregnancy rate than placebo or no treatment, with better result obtained with synthetic progesterone, that means dydrogesterone, than micronized progesterone. When to start progesterone? Progesterone can be started from the day of oocyte retrieval to 2 to 3 days thereafter without affecting the ongoing pregnancy days. Administration of progesterone before oocyte retrieval is associated with a lower progesterone due to premature secretory changes in the endometrium and therefore implantation rate. Decrease in pregnancy rates by 24% was seen when luteal phase support was delayed until 6 days after war compared to 3 days after oocyte retrieval. No difference was found when luteal phase support was started as oocyte retrieval compared to within 24 to 40 hours after oocyte retrieval. Optimal period for luteal phase support, usually given till 8 to 10 weeks, then the placenta takes over the function of producing hormones up to 12 weeks. But according to ASRM guidelines, there is no proven rule in adding progesterone or HCG for luteal support once a pregnancy has been established. In all ART cycles, the LPS luteal phase support should be given till luteal placental shift at around 10 to 12 weeks. Drugs and protocols for luteal support. Other drugs than progesterone, occasionally used combined with progesterone, other drugs are the HCG, estrogen, and GnRIs. Human chorionic gonadotropin, due to structural similarity of HCG with LH, supplementation of HCG in luteal phase stimulates the corporal lutea to secrete endogenous estrogen and progesterone in ART cycle. So, it is documented that delivery rates are more, miscarriage rates are less, and ART cycles supplemented with HCG as compared with those without HCG. But ESRE guideline, 2019 guidelines do not recommend HCG as LPS in HCG-triggered ovarian stimulation cycles, as there is the ovarian hyperstimulation syndrome may occur. Estrogen. As after luteolysis, there is deficiency of estrogen also. It has been postulated that the estrogen along with progesterone is required in IVF cycle. A recent meta-analysis has been shown the beneficial effect of progesterone plus estradiol on clinical pregnancy rates will be high and compared to the progesterone alone. So in RCT, it has been concluded that in ART cycles with GnRIs and agonist protocol, addition with 4 mg estrogen along with progesterone in luteal phase leads to significantly increased pregnancy and implantation rates and decreased miscarriage rates as compared to progesterone alone. However, Cochrane systemic analysis 2015 has shown no significant benefit of adding estrogen in terms of pregnancy rate and live birth rates. So, ESRE 2018 guidelines do not recommend the addition of estradiol with estrogen with progesterone as LPS. Gonadotropin releasing hormone agonist. In RCT, it was found that administration of 0.1 mg decapeptide bolus on day 6 after oocyte retrieval, in addition to routine LPS, can lead to improved implantation and pregnancy rates in women IVF failure. Another evidence of Cochrane Systemic Review 2015, including 7 RCTs, and this shows the live birth and ongoing pregnancy rates were lower in the progesterone-only group than the progesterone plus DNRase A group. But ESHRE 2019 guidelines recommended the use of DNRase agonist as LPS in HCG-triggered IVF-ICSI cycles only in a clinical trial. Luteal phase support algorithm in ART cycles. Here I discussed luteal phase support in ART cycle, progesterone, HCG, GnRH agonist, estrogen, etc. And it is given here. In controlled ovarian stimulation cycles, the study shows that luteal LH serum concentration are significantly higher in patients administered clomiphene citrate in a preliminary study. Other investigators have shown the controlled ovarian stimulation with HMG in the follicular phase was an effective treatment for luteal phase defects associated with recurrent pregnancy loss. These observations could help to explain the benefits of clomiphene citrate and HMG on the luteal phase and the similar pregnancy rates. In intrauterine insemination cycles, in IUI cycles, the women undergoing ovarian stimulation are not totally hypogonadotrophic, and there is no mechanical damage of follicles like IVF cycle. So they need less dose of progesterone in luteal support. Moreover, the half-life of HCG is relatively long. If it at least 5,000 international units are used for the ovulation trigger, a biologically significant amount persists for at least 10 days, by which time the embryo is secreted HCG. Exogenous gonadotrophin increase serum estradiol levels, which will exert negative feedback effect on hypothalamic pituitary axis, leading to abnormal LH secretion and thereby reduce progesterone secretion from corpus luteum. And furthermore, benefit of progesterone in luteal phase has been found only in IUI cycles where the ovulation induction was achieved with exogenous gonadotrophin. Here the IUI cycles, live birth rate was significantly higher with progesterone for luteal phase. There is a study and there is a publication. And in vitro fertilization, in IVF cycles, the use of DNRase analogs and gonadotrophin cause multifollicular development, we know. So the luteal phase defect is more in IVF cycles. For that, the dose of progesterone is required more. LPS in IVF cycle, vaginal progesterone is the mainstay of treatment because easy administration and efficacy equivalent to intramuscular form. So there is the trial. Oral synthetic progesterone has been proven non-inferior to vaginal progesterone in fresh embryo transfer IVF cycles, is probably the recommended for LPS in IVF and ICSI cycles. And progesterone can be started from the day of oocyte retrieve to 2 to 3 days thereafter and continue till 8 weeks or longer. Here, the high uterine contraction at the time of IVF and ET decrease the implantation rate. Here it is shown that where the high uterine contraction, the implantation rate will be low. IVF and ICSI cycle live birth was significantly higher in progesterone for luteal phase support. So IVF and ICSI cycle, always we can say that progesterone will be best for the luteal support. In frozen embryo transfer cycle, frozen embryo and donor embryo transfer cycle, natural cyclicity of the woman is either suppressed or absent. Therefore, there is no corpus luteum formation and there is endogenous progesterone production. In this woman, after embryo transfer, proliferative phase is artificially created this estradiol production, and then exogenous progesterone is added to induce secretory changes in the endometrium. So these cycles with HRT endometrium primed by estrogen should receive progesterone exposure for a minimum period of 3 to 4 days for cleaving embryo transfer and 5 to 6 days before blastocyst transfer. However, the recent meta-analysis, it has been shown that the use of vaginal progesterone in natural FET cycles does not improve the clinical pregnancy rate. This is the implantation, embryo quality, endometricity, and transfer efficiency. So my take-home message is the luteal phase defect is an unavoidable consequence following ART protocols. Progesterone, yes, is the drug of choice for the luteal phase support. HCG, estradiol, DNRase agonist may have a limited role. Different routes of administration have been suggested for the use of progesterone. Oral progesterone, except dydrogesterone, has limited role. Efficacy of intramuscular versus vaginal micronized progesterone are similar, but because of pain associated with side effects of intramuscular injection, vaginal route is the preferred choice. Single injection GnRH agonist 5 to 6 days after oocyte retrieval along with progesterone is also a recent introduction for luteal phase support, though the efficacy is yet to be established. Thank you. Thank you very much for patient sharing. Thank you.
Thank you, chairpersons. Your comments, please. Yeah.
Yeah. Thank you, Dr. Mafruha Khanam, for this very beautiful presentation. And you have expressed all the facts about luteal phase defect and its support, and especially the progesterone, which is the mainstay of the treatment. And I thank the organizers, the Dr. Lakshmi Shrikande, Dr. Supriya Jaswal, Dr. Pragya Mishra, and the entire team of Fertility Enhancement Committee of ISOPAP Seed to Bloom series for giving me the opportunity to chair the session, and the last session, but very important session and very beautiful session with both the speakers and all the chairpersons and presidents and all have attended it. It's very beautiful. The talk was very nice, very informative, and thank you very much.
Yeah. Yes, Vinita. Yes.
Thank you, organizers, for giving me this opportunity to chair such a beautiful session. And Dr. Mahrufa Madam has covered all the details of the luteal phase support topic in such a limited time. She has covered from micronized progesterone to dydrogesterone to SCG, everything, all the minute details she has covered. So I congratulate Madam Mahrufa for this beautiful presentation. Thank you.
Jyoti? I think Jyoti is not here. Yes, Dr. Day, you can sum up before we go to the next session. Yeah. Dr. Ramprasad, please unmute
Yes.
yourself.
Yes. Thank you, madam, for beautiful your luteal phase support, which is very essential, and we have lots of from you. And we are also happy and welcome from India also that we are also having an international speaker who is talking in the South Asian perspective, not only from the India, also from the Bangladesh. Thank you, madam. Thank you.
Thank you,
all.
Dr. Khanam. Thank you so much for being here. And I can't see any questions in the chat box. So, I mean, I think you have made it very
Dr.
clear.
Lakshmi,
Yes.
just Dr. Khanam's views.
Yes, Pragya.
Yeah.
Yes, Pragya, you want to say something?
No, she wants to ask.
Yeah, please go ahead. Yeah. Can't see Pragya. Pragya?
No, I'm trying to switch on my video, but
Okay. Okay, please ask her. Yeah, she's here. Yeah.
No, one good thing, I mean, she said that once a pregnancy test is positive, we really don't, there is no role of giving HCG and all that. That is very true, which you have highlighted. But, one thing that I would like to ask you that what is generally, after IVF, at least in India, most prescriptions that you will find, even after a positive pregnancy test, people are on oral progesterone, people are on vaginal gel, then on top, to top it all, they would be getting injections also. So, they are literally overloaded, with the progesterone. So, which I feel that, it's not ideal practice to subject a patient to oral, vaginal, injectable, all progesterones in all these three delivery modes. So what is your view regarding that? I mean, I do realize that IVF patients are quite anxious also. Clinicians are also anxious that nothing goes wrong in these pregnancies. So what is your view? Do you subject your patient to oral, vaginal, injectable, everything in IVF patients?
Thank you, madam, for your nice question. Actually, I want to cover all the things, but we can use any of them, but not any of them. I usually use when the gestation injection I am actually, this is oil-based injection. This is painful also. Actually, I have to start this one as we have no gel and no injection of aqueous gel, aqueous, water-based injection. And so I have to start the gestational injection, 100 milligram IM, but I usually use with dydrogesterone, but not the vaginal gel. Actually, we have no vaginal gel available in our country. And my experience or personal experience is that one of my patients, she could not use the vaginal gel and adequately, and that time I think the progesterone deficiency this pregnancy loss. So that my experience, we usually use progesterone intramuscularly, that is the natural progesterone, and as well as synthetic progesterone, dydrogesterone, always just. And actually I showed that the HCG injection, I don't usually use this one after the first scan, or sometime it needed, but not the hyperstimulation or PCO patient, that I don't use the HCG injection weekly, 5,000 internationally. Only two.
In India, all these are available. We have aqueous preparations. We have vaginal gel. We have the only thing is that that recent again regarding dydrogesterone. A lot of us, what we are doing, that until we are giving it for luteal phase support, but once the pregnancy test comes as positive, a lot of clinicians are moving over to natural micronized progesterone because of that controversy regarding dydrogesterone. As I know, related to cardiac defects and congenital anomalies. So it's quite debatable. A lot of countries are just not using dydrogesterone once the pregnancy test is positive. So I don't know what Dr. Lakshmi would say.
I just want to listen from Dr. Khanam. Yes, Dr. Khanam.
Actually, I usually use this one. I already mentioned that. And sometimes I also use HCG. But when the pregnancy test will come, then we can use 2 or 3 according to the patient's situation. Otherwise, not.
Because HCG we don't use routinely as a luteal phase support. Your take on this, Pragya? Because we are not using
No, routinely, no.
No, actually, see, I mean, there was a long time back in the Obstetrician and Gynecologist Journal, the official journal by the RCOG. They recommended HCG for luteal phase support. Then again, it was out of the scene. But recently, some people have told me that again, HCG has come into play when it comes to luteal phase support. So, I will have to be honest, because I am giving 2,000 international units twice a week, HCG also for luteal phase support.
In IVF or IUI? IVF or IUI?
No, not for IUI, for IVF. But dydrogesterone, again, I have to be honest that, recently once the pregnancy test comes as positive, I'm switching over to other modes. I'm avoiding dydrogesterone. Although, however, the makers of dydrogesterone say that, no, there is no scare, but still, there's so many articles have come out. So I think it's a good drug initially for luteal phase support. But afterwards, I think we should switch over to natural micronized progesterone or aqueous preparations.
In my practice, Pragya, this SCG I am using in frozen embryo transfer cycles and not in the fresh embryo transfer cycles, because I am really worried about the OHSs in the fresh embryo transfer cycle. But frozen, yes, bi-weekly I am also giving.
Weekly, yes.
Yes, so no more questions? Yeah, Pragya. Yeah.
No, I said it was a very nice lecture, and
Yes.
thank you for bringing Dr. Khanam to ISOPAB.
Yes. Thank you. Thank you, Dr. Khanam. Thank you, Pragya, for initiating that discussion. Supriya, let's move to the next session. Yeah.
Yes, we are over with this first session and the wonderful talk. So I thank the chairpersons and the speaker, Marifa Khanam Madam, for a brilliant talk, and the chairpersons, Dr. Vinita, Dr. Zareen Rahman, Dr. Jyoti Jaiswal and Dr. Ram Prasad Dey for the wonderful interactions. Thank you, Pragyadi, and thank you, Madam, for the interactions. It was wonderful. So now we come to the second scientific session, that is PCOS and infertility. None other than Dr. Lakshmi Shikhande is the speaker. And to chair the session, we have Dr. Archana Verma. She has sent her apologies, so she won't be able to join. So you can tell the next. Dr. K. Geeta Devi. She is from Vijayawada, worked as assistant professor at SRMC Chennai, now working as senior consultant at Ayush Hospitals Vijayawada. She is an active member of Foxy Vijayawada and served as treasurer and secretary and the president for the year 2021-22. She is the fellow of ICOG. Then she is also the president of ISOPAB Vijayawada branch and member of Indian Menopause Society. Her area of interest are high-risk obstetrics and endoscopy. Welcome, Dr. Geeta. And Dr. Manisha Ghate, very popular figure. She is very interested in all the academics. So, and she is the president of Chandrapur OBGY Society, organizing chairperson AMOX Chandrapur, West Zone coordinator of Food and Drug Medical Legal Equipment Committee of Foxy, chairperson Reproductive Tract Infection Committee AMOX, and Secretary General ISOPA Vidabra chapter. And she has got many accolades to her credit. Her special area of interest is laparoscopy, infertility, and colposcopy. Welcome you, Dr. Manisha. Dr. Lata, she is undergraduation from, she has done her undergraduation from Guntur Medical College, Guntur, post-graduation from Rangaram Medical College, and she is APCOG 2015 Treasurer, Yuva Foxy 2018 had been done there, executive member of Works, and presently she is secretary of ISOPAB Society Vijayawada. So, and she's a very active member, and she's going to host the annual conference in Vijayawada that we are looking forward in February 2025. So, welcome you, Dr. Lata.
Thank you, madam.
Over to you, over to the chairpersons to kindly introduce the speaker.
Thank you, Dr. Supriya and Dr. Lakshmi, for giving us this opportunity to chair this Seeds to Bloom program. And respected President Dr. Jana sir, Secretary General Dr. Pragya, past President Dr. Sahu sir, and President-elect Dr. Sulekha ma'am. It's a great privilege for me to introduce Dr. Lakshmi Srikhande. Can you project her? Yeah, she's the immediate past chairperson for ICOG, National Correspondent Editor for Journal of OBGYN India, Joji, and National Corresponding Secretary, Association of Medical Women India, Joint Secretary, Indian Menopause Society, Vice President-elect ISOPAB 2016-17, President ISOPAB Vidarbha Chapter between 19 to 21, Chairperson IMS Education Committee between 21 to 23, and Chairperson of Fertility Enhancement Committee ISOPAB. She's also a member of SAFOG Education Committee and President Association of Medical Women Nagpur, and President Menopause Society Nagpur between 16 and 18, and Senior Vice President for the year 2012 for Foxy, and President Nagpur OBGYN Society between 2005 and 2006. Today, she is going to talk about the PCOS, which is a very common problem in our day-to-day practice. And the number of PCOS people with in adolescents are infertility. It's going up, and now we are seeing many families having this problem, and it's familial clusters we are seeing. And let us hear from Dr. Lakshmi what she says, how it affects infertility. The stage is yours, Dr. Lakshmi.
Thank you. Thank you, Dr. Geeta, for your kind words. Friends, I am going to deliberate on PCOS and infertility. You all will agree with me that PCOS is one condition where people always like to agree to disagree. Over the years, these disagreements have continued. The criteria for the diagnosis keeps on changing. So the management guidelines also, which keeps on changing. So the outline of my presentation is, first we are discussing the lifestyle interventions, then the first line management in managing infertility, second line, and the third line. So to start with, just in short, what is PCOS? We all know, being gynecologist, that it is a genetic, hormone, metabolic, and reproductive disorder which affects women, and it is the leading cause of female infertility. As far as incidence is concerned, you can see that 1 in 10 women are affected by PCOS. Sahiti, why this is happening repeatedly? Hello? Am I audible, Supriya?
Yes, you are audible.
Yeah. So the common signs and symptoms we all are familiar with. So I'm moving to the reasons for female infertility. We all know that unexplained infertility, around 29%, uterine factor 5%, tubal factor 40%, and ovulatory disorder accounts for 40% of female infertility. And in this category, PCOS accounts for 85% of ovulatory infertility in these women. But remember, when we are discussing infertility and PCOS, not all women who are having PCOS, they experience infertility. However, PCOS is the primary cause of anovulatory infertility. So don't scare your patients when she comes with PCOS that you will be having some infertility issues. So this is the algorithm for managing PCOS and infertility. Whenever any woman comes to you with oligomenorrhea and infertility, of course, you have to rule out all other etiologies. Don't forget to screen her for diabetes, for hyperlipidemia, hypothyroidism, and see for the BMI. Don't forget to do routine prenatal counseling and the prenatal vaccination for her. If she is obese, that is BMI is more than 27, you have to emphasize about the lifestyle interventions. Then comes the role of routine infertility evaluation in the form of evaluation of the male partner and the evaluation of female partner in the form of tubal patency and the endometrium, that is the uterine factors. And then if there is an anovulation or oligoanovulation, we have to start the ovulation induction. So this is the algorithm given by the ISHRE latest guidelines when we have to manage PCOS and infertility. Remember, the first line non-pharmac management for infertility is lifestyle intervention. The guidelines have given lot of emphasis to the lifestyle intervention in these women. Even lean PCO women, they need lifestyle intervention before you proceed with the ovulation induction. Then the first line management is letrozole, clomiphene, CC plus metformin, metformin alone, and gonadotrophins. Second line is gonadotrophins and laparoscopic ovarian drilling. And third line is IVF ICSI. I have put gonadotrophins in first line as well as in second line. I will explain in my future slides why this is so. So let us first discuss about the lifestyle intervention, which guidelines are emphasizing. It is very easy to say lifestyle, but we should be able to explain to our patients what do we mean by lifestyle interventions. So lifestyle interventions has 4 components, that is behavioral strategies, dietary intervention, exercise intervention, and if she is obese, the weight management is included here. So this is a broad things which are included in lifestyle interventions, that is the diet, sleep patterns, then the infection prevention control, exercise, maintaining healthy weight. When we come across females who are having BMI more than 27, we have to advise weight loss. Again, this has to be done smartly from our side, and also we have to give smart goal to the patient. So what is this smart goal for the patient? It has to be specific, measurable, achievable, realistic, and timely. Don't tell her ki you go and lose your 5 kgs, 10 kgs, 15 kgs and then come back to me. 5 to 10% of her total weight loss will help her in having ovulatory cycles. So you can give her time-bound weight loss goal, which she has to assess. Now, how much? I have already said 5 to 10%. And this is considered as successful weight reduction, but this 5 to 10% should be done within 6 months. Now, the million-dollar question is how to lose weight. Which diet is the best and how much calorie deficit should be prescribed? Because standalone clinics, we are not having dietitians or nutritionists in our clinic. So as a gynecologist, we have to double up as a counselor and we have to do the nutritional counseling. Listen now, in this internet era, all our patients are doing so much of Google search that they know each and everything. As a doctor, it is our duty to tell them what is wrong and what is right with the information which they have procured from the Google. So tell them that no one dietary type is recommended, whether it's a crash diet, it is a herbal diet, I don't know. There are so many types of diets which are popular on internet. So tell them no one, they don't have to follow any kind of that diet protocol. To achieve weight loss in those women who are having excess weight, the energy deficit of 30% or roughly 500 to 750 kilocalorie per day can be prescribed for these women. But when you are prescribing this, remember that what is her individual energy requirement, what is her body fat, food preferences, and how much physical activity she is doing in day-to-day life. That was in a nutshell about diet. Now this has to be combined with exercise. So how much exercise will you recommend for mild weight loss and for moderate weight loss? Again, this is from the guidelines that for mild weight loss, she has to do minimum 150 minutes per week of moderate intensity physical activity or 75 minutes per week of vigorous intensity or an equivalent combination of both, including muscle strengthening activities on 2 non-consecutive days per week. For moderate weight loss, she has to increase this a minimum of 250 minutes per week of moderate intensity or 150 minutes per week of vigorous intensity. When we come across obese woman, now everybody is asking you to prescribe some pill. So what is the role of anti-obesity agents? Remember, guidelines are saying that pharmacological anti-obesity agent should be considered an experimental therapy. But friends, to modify these guidelines in practical scenario, if she is obese, now we are having many good anti-obesity drugs. But we as a gynecologist are not supposed to prescribe those drugs, refer her to an endocrinologist, and there are many drugs which can help her to enhance her weight loss along with the diet and exercise. Role of bariatric surgery. Again, guidelines are saying no, but in our practical scenario, now bariatric surgeries are having a good safety profile. Again, take help of your endocrinologist friends, whether they want to manage these this obesity with the drugs, that is newer drugs, or this patient really needs bariatric surgery. But when she needs bariatric surgery, you have to definitely counsel her about the risk versus the benefits. And if she is undergoing the bariatric surgery, she has to wait for 1 year before she can start her infertility treatment. Now, what is the role of tubal patency test when we are managing these PCOS and infertility? Of course, you have to do the semen parameters, but tubal patency test should be considered prior to ovulation induction in those women who are having suspected tubal infertility. I will just stop sharing. Just a minute. So sorry. So what I mean by suspecting tubal patency, that if she has undergone DNC prior to that, or if she is giving history of any pelvic inflammatory disease, then yes, tubal patency test is mandatory. Now coming to the ovulation induction principles, first and foremost is you rule out pregnancy. Because if she is having irregular cycles, you never know that she might be pregnant. So do a urine pregnancy test before you take her for ovulation induction. And you don't have unsuccessful prolonged use of ovulation induction agents. Now, these are the first line agents, but before you start any kind of ovulation induction, day 2 scan is a must. So this is the format given by the guidelines. When you are reporting your day 2 scan, you have to report in this format. Mention LMP, what transducer you are using, whether it is abdominal approach, vaginal approach, how many total follicles per ovary, measuring 2 to 9 millimeter, 3 dimensions and volume of each ovary you have to mention, the endometrial thickness you have to mention, and if you see other ovarian or uterine pathology, you have to mention on your day 2 scan. Now, aromatase inhibitor, you have to start from 2.5 to 5 milligram from day 2, 3, 4, and 5. And from day 8 onwards, start follicular monitoring. Advantage over CC is that it has no anti-estrogenic effect and it gives you monofollicular development. Clomiphene citrate you can use, but the guidelines are mentioning that letrozole is the first line management as far as PCO is concerned. But if you are using clomiphene, you can increase the dose in an increment of 50 milligram. Never go above the dose of 150 milligram because it will increase the anti-estrogenic effects. The monitoring is same as that of letrozole. You should know when to stop these ovulation drugs. When the 6 ovulatory cycles, they fail to give you a pregnancy, you don't get any ovulation with highest permissible dose, and when you get endometrial thickness repeatedly, which is less than 7 millimeter, you should stop your oral ovulations. When to add metformin to those patients who are clomiphene resistant, who are having BMI more than 25, you can add metformin to your oral ovulations. Metformin alone in our clinical practice, we are not using as an ovulation induction agent. Now coming to the second line, it is gonadotrophins and laparoscopic ovarian drilling. Gonadotrophins as second line in those women who have failed to conceive with your first line management. But gonadotrophins in a selected group of women can be the first line management as well. Who are these women? Where gonadotrophins are available and affordable. There is a presence of ultrasound monitoring, and when you counsel them on the cost and potential risk of multiple pregnancy. So if she has undergone many cycles already at some other places and you want to bring her on the fast track, gonadotropins can be the first line management. When you are starting ovulation induction with gonadotropins, you have to consider the cost, the expertise required for monitoring, the risk and implications of multiple pregnancy and OHSS. Now, question is which gonadotropins? Market is flooded with HMG, highly purified HMG, urinary FSH, highly purified FSH, and recombinant FSH. You can use any gonadotropins, including urinary HMG, safely. Now, there are n number of papers which are saying that urinary HMG is not inferior to other recombinant products, because if you are using recombinant FSH, you will have to add recombinant LH in your stimulation protocols, which adds to the cost for that patient. Now, for non-IVF gonadotropin cycles, what should be the starting dose? The starting dose of gonadotropins for IUI cycle depends on the age of the female, her antral follicular count, her AMH values, and of course, if she has already undergone gonadotropin therapy, then what was the response to that previous cycle? So safely, if she is less than 135 years, non-PCO, you can start with 150. But if she is PCO and less than 35, start with 75. And if she is more than 35, start with 150. How we will monitor? Give her gonadotropins on day 2, 3, 4, 5, and 6. On day 7, you should do the transvaginal ultrasound. And what you will be looking on day 7? You will be looking for the follicles which are more than 10 millimeter in size. If there are 2 to 3, continue with the same dose. 4 to 6, you can continue with the same, or you can taper the dose. But if there are more than 6 follicles, you should taper the dose and look for OHSS. If on day 7 you are getting follicles which are less than 10 millimeter, then definitely you have to increase the dose. And when lead follicle is 18 millimeter, you can give trigger for ovulation. Now you can combine oral ovulogens with gonadotropins. Here, day 2, 3, 4, you are giving oral ovulogens. 5, 6, oral ovulogens plus gonadotropins. Day 7 and 8, gonadotropins alone. And from day 9 onwards, you start your ultrasound monitoring, and the rest is same, which I have shown in the previous slide. Remember, when I say monitoring, it has to be follicular monitoring as well as the endometrial thickness monitoring. When to give trigger? If it is a standalone oral ovulation cycle, the follicle diameter should be between 20 to 22 millimeter. If it is gonadotropin cycle, then follicle size should be between 18 to 20 millimeter. And the trigger dose is 5,000 to 1,000 IU units. But in IUI cycles, everyone should know when not to give trigger. When there are more than 3 mature follicles, you should withhold your trigger for the risk of multiple pregnancy more than the risk of OHSS. And everybody should be very, very familiar with the management of OHSS, the pattern of OHSS, which is early OHSS and late OHSS. Because in IUI cycles, prevention is better than cure. Luteal phase has already been well covered by Dr. Khanam, so I am skipping these slides. But for oral ovulation cycle, luteal phase support is not mandatory. For gonadotropin cycle, it is mandatory. PCO drilling, I know for in this IVF era, everybody has ruled out that we should not do, but it has its own place in our practice. And which woman will benefit? Best. They are less than 3 years, thin PCOS, and who are having high LH. These are the pros and cons of laparoscopic ovarian drilling versus gonadotropin stimulation. IVF is, of course, the third line management. Which protocol? Nowadays, everyone has shifted to antagonist protocol, agonist trigger, and we are freezing all the embryos in that cycle so that practically speaking, we all are having OHSS free clinic when we are dealing with PCOS and IVF. In vitro maturation is coming back in a big way, especially in cases of PCOS. But don't forget your role. The moment the woman becomes pregnant, everybody forgets that this lady was having PCOS. Remember, she is having increased risk of early pregnancy loss, gestational diabetes, PIH, and SGA babies in this pregnancy. Also, don't forget to counsel her about the late sequelae, that is, an increased risk of diabetes mellitus, hypertension, dyslipidemia, and the risk of endometrial cancer later in life. So, to summarize, the lifestyle management, then oral ovulogence, then gonadotropins, and then IVF. So, friends, it's not what you give, it is the way you give it, which will give you maximum clinical pregnancy rate in a PCOS. Thank you. So,
One question, please. Dr. Lakshmi, wonderful talk on PCOS. Very nicely you have covered every aspect of it, and congratulations for this excellent talk. Now, I have few questions.
yeah,
They're all practical questions.
yes,
One is we find very high LH, and in some patients, those with high LH, we find that AMH level is also very high. And for on practical purpose, what we see, they actually don't respond to the first line treatment.
yes.
Can you tell me what should we do if we find very high LH level and we want to start the first line treatment?
With high LH, you want to start the first line, you are contradicting yourself that they don't respond to the first line.
Yes, but still, the patient would prefer to have the first line treatment like clonazepam or letrozole, and she's coming for the first time. When you investigate, you find that the LH is very high. And often I have seen that those patients with high LH have got high AMH. No, I want to know about these two and how you manage. And I have another question. Adolescent PCOS, few patients I had who all the other causes of secondary amenorrhea are ruled out, and still the amenorrhea persists. What will be the management? Only
Yeah.
these three
We will
questions.
go one by one. Dr. Khanam, would you like to answer on a first question?
Actually, this is also question. This is usually we see that at the day 2 follicular basement hormone analysis, at baseline hormone analysis, day 2 or day 3, there is the LS is very high, like 19, 17, like that. So I usually do that counseling with the patients, and the patient is living with her husband, and the first line treatment, just she will start it, then I just down regulate this one with the Marvelon type oral pill, OCP, with the 21 days, or sometimes it needed more, like 30 or 40 days. Then just to after that down regulation, or after that completion of the OCP, just patient will come to me, and when the means start, she will do her LH at that day 2 or day 3. And if I see that LH below 7 or 6 like that, then I start the treatment like that.
Sometimes only these OCPs, they don't work. We have seen that OCPs alone.
Yeah,
I
Pragya.
think
Yes, Pragya.
Dr. Pragya will answer.
Yes, Pragya.
So, see, with these patients, a high AMH, obviously,
High
we are
LH
talking.
High LH,
Yeah,
and
we are
high
talking about
LH.
Yes, yes. We are talking
they're
about
usually
PCOS.
non-respondent.
Yes,
LH.
yes, that's what I'm saying. That these are patients, with PCOS, and the fact that, they have very high AMH, it means they have insulin resistance and hyperinsulinemia. So what I would do for these patients, I would put them on metformin. I would start metformin, and and tell them that this drug would just continue in the background, and after 2 months you will see that ovulogens work very well with these patients. So typical, because I see so many patients with PCOS, and I mean almost 98 to 99% of the times I have been successful in giving them a pregnancy. And the wonder drug is metformin, I would say. It's metformin which actually reduces the root cause of PCOS, which is insulin resistance. Metformin helps with that. And so put them on metformin. Don't even give ovulogens in the first 2-3 cycles. Call them back after 2 or 3 cycles, and then start, and you can repeat LH also. I mean, AMH is not something which has to be repeated every now and then, but serum LH, if you want to repeat, you can repeat on day 2, day 3. You will find it lower also, and the same patient, responds beautifully to the ovulogens and the gonadotropins.
How much dose you would like to give metformin, Dr. Pragya?
Yeah,
how much dose?
Yeah, see, recently I've been giving this combination of metformin and myoanisitol. I think I've mentioned in previous webinars also. So, the combination drug therapy which is available in the market with 500 milligrams of metformin and 1 gram of myoanisitol. So, I mean, I have switched over to that. But earlier, I used to start with 500 milligrams week 1, then 500 SR week 2, then from week 3 onwards, 1000 SR, which is equivalent to 1500. So it depends, what is available to you, whether SR is available to you or you have, 1000, 1500 that way, because so that in order to reduce the side effects. So from
but the old teaching is 1500 to 1 gram and 2 grams also. But nowadays we are all prescribing only 500 milligrams sustained release twice a day, along with my
sustained release 500 twice a day is enough.
Is enough. You don't have to go for
but my practice
1500
is,
milligrams.
plain metformin 500 milligrams week 1, then 500 SR week 2, and then 1000 SR from week 3 onwards. I usually give that dose.
Dr. Geeta, we have 850 SR also available. So we can 850 SR BD, so that covers the ideal dose, that is 1500. All the guidelines are saying 1500. So 850 SR BD.
Depends on her weight also. Depends on her weight. So if she's if I find that her BMI is more, if she's 27, 28 BMI like that way, then I would also go for 850 SR. In that case, then I change my prescription a bit by giving 500 milligrams and 850 and then 850 SR that way. I mean, you just have to increase the dose.
Yes. You are absolutely right, because we have to have the metformin in increments to reduce the chances of GI side effects.
Now, and also till what time should be continued? And also till what time it should be continued?
It can be continued in the pregnancy, first trimester also. It does not have any side effects.
So throughout pregnancy, she can continue throughout pregnancy.
Yeah, it will help her in reducing her chances of miscarriages, and later on it will help her in reducing the chances of gestational diabetes and all. So
but
there
we
are
need
studies.
to do. We need to do GCT in first trimester. Then we have to stop it or not.
Yeah, you have to do GTT, but her question is whether we can continue. Yes, you can continue.
But before doing GTT, we need to stop it or not?
No.
Guidelines.
Yes, Pragya.
Guidelines also say that if a patient on PCOS who has conceived while she's on metformin, then you can easily continue with metformin. But in other patients, they would say that you stop metformin just after 12 weeks, and you can, and depending on her glucose tolerance test later on in pregnancy, you can restart, because in other patients we need to stop metformin. In PCOS patients, if she has conceived, you just carry on. Now, one more problem is there. Some patients, they are so intolerant to metformin.
Yeah.
Like, I keep hoping that, she takes it, but she comes back saying that, she just cannot tolerate, in spite of all the precautions that we take, in slowly increasing the dose and all that. Now, in those patients, then it becomes a bit of a problem, because, definitely metformin is a wonder drug. There's no doubt about it. Then in those cases, what I do is, I switch over to this D-caro-inositol, myo-inositol combinations, because I don't have much choice, because she's not, although I know that metformin will help her more, but then I do have to switch over. I mean, just myo-inositol, caro-inositol doesn't work as well as metformin.
Dr. Lakshmi, can I ask you one question? Today I have seen one infertility patient married for 4 years, and a typical PCO, she won't get periods. If she gets, she will continue for days together for a month, every day spotting or heavy bleeding on and off, like that. And if she comes to you with infertility and AUB-O pattern, you would like to treat AUB-O first, or directly you would like to induce her? Because ovulation induction will reduce the endometrial hyperplasia also, they say. But it's very difficult to, first better treat her endometrial hyperplasia or that irregular bleeding with progestogens and OC pills, or then induce her later, or you prefer to induce her in the beginning itself?
Yeah, Pragya wants to say. Yeah.
No, you say.
No.
Sorry, I'm interrupting.
No. Pragya, please comment here.
Okay. No, because even I get patients like this. Infertility patients, we've hardly got, or even if, I've done just one cycle of IUI, and after that, she has this problem of AUB, prolonged periods and all that. So definitely, in these patients, I would give her progestogens, treat her AUB, give her cyclical progestogens for 2 cycles, minimum, like 2 cycles. After that, that problem resolves, and then go for ovulation induction. I mean, touchwood, I've been very lucky, with my infertility patients. So I usually, that's my practice, give for 2 cycles and then switch over to ovulation induction, as you were asking. Because, it won't work. I mean, if she's having, we definitely have to alleviate any patient's symptoms, and always give priority. Like I said, that sometimes if they are intolerant to metformin, we cannot continue with metformin, however good drug that may be for insulin resistance. So same, if she has problem of AUB, we have to tackle that problem before, we embark upon her infertility treatment.
Yeah,
So you would like to give cyclical progestogens or
yes, cyclical
continuous
progestogen, cyclical. Now, Dr. Sulekha's second answer. Pragya, she is saying ki after giving everything, your adolescent patient is still amenorrheic. That was the question, Pandey madam?
No. Second question was, I had phase 3 patients in adolescent group having secondary amenorrhea. Then evaluated thoroughly every angle, and first we gave progesterone withdrawal, endometrium being normal and everything, endometrial thickness being normal, and all the hormonal parameters are normal, and she did not respond to progesterone or estrogen progesterone withdrawal bleeding. Kept on giving estrogen progesterone, thinking that probably in cyclical order she will respond, never responded. Sent the patient to the BHU professor of endocrinology, because for few years, 1 or 2 years, she was suffering. Now, can you throw the light? And every person diagnosis is PCOS, but she doesn't respond, and the secondary amenorrhea continues. And thoroughly we have investigated in the line of COX and all the other parameters, all the other organs. But I don't know how. And there were 2 or 3 patients of mine who continued to having secondary amenorrhea.
Because if you are saying ki endometrial thickness is good and she is not having withdrawal even for estrogen, progesterone
Yeah,
withdrawal.
nothing. They were not responding. Estrogen, progesterone withdrawal, they were not responding. High dose of estrogen and progesterone not responding.
No, madam. Then to HPO, I mean, it's not.
And
Yes, Pragya.
I didn't know what to do with
But
this.
madam is saying that, these were cases of the adolescent PCOS.
Yes.
That's what
Adolescents,
she's
they
saying.
were in 20s and they were all unmarried, not
19, yes, 1920.
And
I've also had
23 years of age.
same.
And normal periods earlier, and then
I've
suddenly
also
it stopped.
I've also had similar patients, young girls, 19, 20, and they've seen me before marriage and after marriage also. And, they had gone to so many clinics where they had been they had put them on OC pills and withdrawal bleedings and all. When I did their AMH was so high, 25, 26. I've had patients with 26 AMH, 30 AMH like that. And again, I would say the wonder drug metformin. And at least in my case, metformin worked. I've put them on metformin for a year, for 2, and those patients have fallen pregnant also after marriage. And that is the only situation where I
They were all
repeat
weak.
my
They were not obese, nothing. And with having normal fasting sugar and fasting insulin, every
what about
parameter
no,
normal.
Yes. No, but serum,
So
in those
ultimately,
cases,
what I
we
did,
should.
I also got fed up and said, दिल्ली में चले जाओ वहाँ के एम्स के एंडोक्रिनोलॉजिस्ट से कंसल्ट करो.
Now, ma'am, can I share my one experience
No,
Yes,
so
regarding this topic?
Yeah, I'll just
Yes.
finish this. So actually, only in these situations, these are cases where normally I never repeat AMH. But at some in adolescent PCOS, where I feel that they are really resistant cases, and first serum AMH has come as so high. In those patients, after putting them on metformin for a year or so, or even 12 months, 18 months, I have repeated serum AMH, and then it has gone down from 25, 26, it has gone down to 11, and these patients have started menstruating. And I've also had, ma'am, quite a few adolescent girls like that. So
Would you like to prescribe a metformin for the
Dr.
lean
Pragya, I
PCOS?
will try this.
Hmm.
But still the patients, a lot of patients are coming with all
Now,
this.
I have one experience with such adolescent girls. Now, these adolescent girls are, suppose she is not obese, she is lean, and yet she is not menstruating. All the parameters are normal. And we concentrate on the parameters of hormonal parameters and ultrasound and all. But one thing which I felt that in these girls, we miss the hypothalamic amenorrhea, in which case they are anorexic and they are full of stress, and these patients of hypothalamic amenorrhea are very resistant. So if everything is normal, we have to concentrate on their diet and lifestyle and stress-free environment, and maybe after giving proper diet and stress-free environment and a proper weight also, a certain amount of BMI is also needed for menstruating. This I'm talking about low weight and low BMI people, not for obese. For lean ones, certain amount of BMI is needed for menstruating. So I think we should concentrate on diet and mental health also.
Thank you, madam.
Yes. So now I can see Manisha, the chairpersons are here. Chairpersons, would you like to comment? Yeah, for the second session.
Yes, madam.
Yeah.
Actually, PCOS is such a vast topic that every time we find new modalities, new guidelines popping up for the management. And as we all know, that your talk was on PCOS and infertility related. And yes, it forms the major chunk of cause for not conceiving. And Lakshmi madam, you have very elaborated, very much simplified the topic. How should we proceed with the conservative management and how to we do our IUI patients follow up and then proceeding for IVF, what to do, what to not do, everything you have cleared in your slides. Yes, of course, we have to stress very much on lifestyle modification, what you have told us, because even the 5% of the weight loss is going to help her. And अगर हम ऐसे बताते हैं उनको कि तुम लोगों ने अगर 5% भी weight loss कर दे, then you are sure that you can conceive, you have the chances of conceiving. तो बहुत बड़ा moral boosting support भी होता है ये बहुत बार patient को conceive करने में, and it helps much of the time. Yes, then importance of day 2 scan, which you have very much stressed out, and all other things. Yes, very nice, ma'am. It was such an enlightening session from your side. And the question answers, which Sulekha madam has also popped out. Yes, we got many of our answers for our routine patients with that. Thank you, madam. Thank you, madam.
So, yes, so I think Manisha, you are here, Geeta is here, Dr. Archana is not here, na? And Dr. Lata.
Yes, ma'am. Yes, ma'am.
Yeah, so Lata, you want to say something? Yeah.
Yes, ma'am.
Lata, yeah.
Everybody has said the same thing, because as we know that PCO is a major problem in our society. Every OP we see more than half people having PCO. So especially the adolescent PCO, and they have to be taught and counseled. The parents have to be counseled to raise the children in a proper way, avoiding this screen time, especially because the children nowadays are more into watching screen. Their screen time is more, and so their physical activity is very much decreased, so thereby leading to obesity, childhood obesity, followed by adolescent obesity, and then PCO, and later on infertility. So it should be started from the childhood itself. So you have very concisely described the PCO and infertility in a very short time. It's very difficult to concise it in such a short time, but it was a nice presentation.
Yes.
Thank you,
Madam. One question more. Madam, nowadays, these pharma people, they are again coming up with the combination of DCI and MI along with berberine. What is your thinking and what is your take for this type of product for the use in PCOS?
Manisha, the latest guidelines are saying that there is no role of myoinositol in PCOS management, but all said and done about the guidelines, in our day-to-day practice, we all are using myoinositol in all cases of PCOS.
Yes.
Yes, I try to avoid the combination, but yes, we are giving metformin as well as myoinositol.
But berberine, I don't think has any role.
Yes.
No, berberine, no, but the myoinositol I'm saying.
She was talking about berberine.
Okay,
also.
okay.
Yeah, I am asking you about this. What is your opinion about
berberine? No.
Berberine.
No.
So what about the main treatment modality for the lean PCO patients?
Even in lean PCOS patients, guidelines are saying that there is a role of lifestyle intervention. We don't need weight loss in these patients, but there is insulin resistance. So you have to emphasize the importance of exercise in reducing insulin resistance. And you have to emphasize the importance of the balanced diet. I mean, they should avoid the junk food and all. So in lean PCOS also, there is a role of lifestyle intervention.
So for them, metformin is not required as
yeah,
they are
but
not
diet and exercise, which will help them in reducing the insulin resistance.
Yes.
Yes. So now I think our scientific sessions are over. So now we are moving towards the felicitation ceremony. And I'm so happy that we are having the Legacy Leadership Awards for our current President, Secretary, President-elect, and all the past presidents. So Dr. Narayan Jana, I know he has some commitments, so he has left. We will email him his certificate. So this is the Legacy Leadership Award. Friends, you all know we all are isopabians. So the World Prematurity Day was on Sunday, 17th November. So on this occasion, we decided to felicitate our office bearers, past presidents, chapter presidents, and chapter secretaries for tirelessly working towards this goal of reducing the maternal morbidity and mortality as well as the neonatal mortality and morbidity. So on the certificates, we have printed that in recognition of exemplary leadership and unwavering dedication towards enhancing fertility and reproductive health, and also contributing to a bright future for mothers and newborns on the occasion of World Prematurity Day, that is 17th November 2024. So this was for Dr. Narayan Jana. He has left, but our President-elect, Dr. Sulekha Pandey, is here. Madam, this is the token of gratitude and appreciation for all the unwavering work you are doing. So this is for you. We will email you, and I can see Pragya. Pragya, are you here? This this is the recognition for our Secretary General, Dr. Pragya Mishra. And Pragya, we will email this certificate to you. And similarly, we have prepared this certificate for Dr. Arup Kumar Maji. He said he is having a teaching workshop at the same time, that is 4:30 p.m. to 7 p.m. So that is why he is not here with us. But this is certificate is in recognition of his services, and we will email this certificate to him. Dr. Gangadhar Sahu sir was here, but the award ceremony was after the talk. So sir, so sorry, we missed giving to you virtually in your presence. But again, we will email this certificate to you. Then rest of the past presidents are not here, so I am not showing the certificates, but this is the similar certificate which we have prepared for all the past presidents. Then the next category of award was for the office bearers, the current office bearers. And the office bearers I have taken from website till 2020. So I can see Ranjana Khanna is here. Dr. Ramprasad Day was here. Dr. Ramprasad, again, he is being a teacher, he has left. So this is for Dr. Ramprasad Day, the Distinguished Service Award, which he is doing tirelessly for the ISOPAB work.
Madam, are you sharing the screen?
अच्छा नहीं, ये वाला नहीं किया मैंने, वो लीगेसी वाला दिखाया था ना?
हाँ, yes.
हाँ, एक मिनट, ये वाला नहीं.
But बड़ा नहीं दिखाया था. Small.
अच्छा, मैंने तो किया था, यहाँ से कुछ स्क्रीन का प्रॉब्लम आ रहा है. अच्छा, एक मिनट, अभी तुम देखते रहो. ये पूरा आया स्क्रीन?
नो,
छोटे छोटे हैं.
नहीं आया?
नहीं मैम, वो पूरे
बहुत छोटे छोटे दिख रहे हैं.
Thumbnails.
नहीं यार, मेरे स्क्रीन पे तो बड़ा दिख रहा है.
नहीं,
क्योंकि ये जेपीजी फॉर्मेट है, सो आई एम सरप्राइज्ड कि व्हाई, आई मीन व्हाट टू डू. तुमको बहुत छोटा छोटा दिख रहा है?
हाँ, वो एक लाइन से सबका दिख रहा है इन पोस्टर फॉर्म, मतलब सारे लोगों का छोटा छोटा एक साथ दिख रहा है मैडम. वो जब आप क्लिक कर रहे हो तो बड़ा नहीं हो रहा है.
हाँ, तो फिर मेरे इसमें कुछ प्रॉब्लम है, क्या करूँ?
यू स्टॉप शेयर एंड अगेन शेयर, ऐसा
हाँ,
देखिए.
करके देखती हूँ, एक सेकेंड. स्टॉप शेयर, क्योंकि ये सेकंड कैटेगरी का आई हैव प्रिपेयर्ड फॉर ऑल द current office bearers and the past office bearers till 2020, which names I got from the website. I will just reshare.
Thank you very much.
नहीं, you all are working so tirelessly, so it's my honor and privilege. Now फिर से stamp size दिख रहा है?
Yes,
Now
madam.
if I click on Dr. Ramprasad Day का certificate, बड़ा
now it has come.
Yeah.
Yes.
Yeah, so this is the Distinguished Service Award for our current office bearers and the past office bearers for in recognition of your services to the ISOPAB. So Dr.
Close it,
Ramprasad,
ma'am. Okay. Next one, if you open, you can click on the right arrow, ma'am, so that it will move to the next.
Yeah, it will move. Okay.
Yeah.
Okay.
So this is Dr. Ranjana Khanna. Thank you so much. You are here since the beginning.
Yes.
Can you see the full certificate?
Yes. Thank you so much. Thank you so
Yes.
much.
हाँ, अरे वाह. Dr.
Lakshmi, you did a lot for the ICOG also. Then I was governing council member also.
I did this Isopub Hall of Fame when I was president of Vidarbha Isopub. So that was Isopub Hall of Fame 1. This is Isopub Hall of Fame 2.
Okay.
We all need appreciation. Na? We all are doing so working hard. So this is for all our office bearers. So those who are not here, I will be emailing them the certificates. So I was just looking who is present. These are all not. Saswati also sent apologies. Then these certificates are same. Ruchika is not here, na? Pragya here. Then this is the all current office bearers and past presidents. Then the third category we had is the Pillars of Strength Award, because all our chapter presidents, they are the pillars of strength for all the activities of our national ISOPA. So who is the chapter president who is present here? Geeta is here? Vijayawada?
Yes, ma'am.
I am just searching Geeta.
Yeah, it is there.
You can see Geeta?
23, madam.
I am also there.
Yeah, Geeta. Now you can see bigger certificate?
Yes, ma'am.
Yeah.
Yeah, so this is in recognition, and we have nicely printed the names and your designation for all the chapter presidents that you are president of Vijayawada chapter, Andhra Pradesh. Yeah, so this is the Pillar of Strength Award is for all the chapter presidents. Any other chapter president who is present here?
I am here, but you've already shown me.
Yeah.
Right.
So you will be getting 2 or 3 certificates then. Because your certificate is here also.
Yeah.
Yeah. And same way, we have not forgotten our chapter secretaries, because they are the backbone for all the activities of their chapters. So we have given them the this award, Beacon of Support Award. So this we have prepared for all the chapter secretaries. Just a minute. I will just show the award which we have prepared for them. My Zoom is giving me dhoka. I will just share their award. Can you see? Supriya? Who is the secretary who is present here? So I can just show their certificate on the full.
Yeah, madam. Manisha Ghatte.
Manisha Ghatte.
Even Sinha also I saw.
Yes,
23 also, madam.
Yeah, Manisha, can you see? This is the certificate which you will be receiving in your email. Can you see the full
Make
screen?
it full screen, madam. Make it full screen.
करा मैडम.
किया फिर से स्टॉप शेयर करके करना पड़ेगा, रुको. ये JPG फॉर्मेट में है ना, तो आई एम नॉट यूज. डॉक्टर आभा रानी इज हियर, आई विल शो हर. मनीषा का, मनीषा दिखा अभी फुल स्क्रीन?
नहीं मैडम.
अरे यार, पर ये मनीषा का है. रुको, इतना मेहनत किया है मैंने, एक एक अवार्ड, एक एक नाम सबका लिखवाने का. एंड ऑफिस बेरर्स का तो विद फोटो है, क्योंकि वेबसाइट से हमको फोटो मिल गया.
वहीं पे तो था.
हाँ,
उसके नीचे वाला रैक पे देखिए.
आपका अपना सर्टिफिकेट है कि नहीं?
देखो अभी आया.
लक्ष्मी?
नहीं मैडम, मेरा नहीं है. अभी आपने बोला तो बनवा लूंगी. हमने हर का. मनीषा, ये तुम्हारा है. आई डोंट नो व्हाई इट इज नॉट सीन, बट सारे चैप्टर सेक्रेटरीज का है. एंड दिस इज द 4th कैटेगरी ऑफ अवार्ड, दैट इज बीकन ऑफ सपोर्ट अवार्ड. अगेन दिस इज विथ नेम एंड योर डेजिग्नेशन.
Okay.
आई विल जस्ट शो डॉक्टर आभा रानी सिन्हा का. एक मिनट. नहीं, स्क्रीन शेयरिंग हैज, आई डोंट नो. साहिती, आर यू विथ मी?
Yes, ma'am.
तुम्हारी तरफ से प्रॉब्लम नहीं है ना साहिती?
No, ma'am.
मैं आभा रानी सिन्हा का दिखाना चाहूंगी यार.
मैडम, वो जो नेशनल ऑफिस बेयर्स हैं वो वाला आप खोलिएगा तो मैं नहीं याद है. प्रज्ञा मिश्रा, आभादी, रंजना सिन्हा.
ये अभी मेरा छोटा छोटा स्टैम्प जैसा दिख रहा होगा. ये फुल
हाँ, मेरा दिख रहा है. थैंक यू सो मच लक्ष्मी मैडम.
ये डॉक्टर आभा रानी सिन्हा के लिए है.
थैंक यू फॉर योर अवार्ड.
नहीं. सो सब
थैंक्स अ लॉट लक्ष्मी.
मैडम, अभी बड़ा हुआ था, वैसे नहीं हो सकता है.
क्या
बड़ा करके.
हाँ, सुप्रिया
रियली वेरी हार्ड वर्किंग.
सुप्रिया
थैंक यू फॉर दैट.
सुप्रिया तुम्हारा कहाँ है?
Lakshmi, do I have your
हमने हर कमिटी
permission to
चेयरपर्सन
leave now?
यस मैडम, शीला,
Thank you
रुचिका
so
और
much.
शोभा
dear.
गुड़ी का भी बनाया है। सुप्रिया तुम्हारा किधर है यार? तुम इतनी हार्ड वर्किंग हो, तुम्हारा तो दिखाऊं। दिख रहा है फुल स्क्रीन?
ये सुप्रिया का है।
No, ma'am.
यस
Ma'am, below there
इसको
will be
full
like
screen
gallery
करिएगा।
symbol. If you click on that, you can see, ma'am.
हाँ,
Gallery symbol.
गैलरी सिंबल कहाँ है?
पर
मैडम,
Okay, once minimize this window, ma'am. Minimize this window. Sometimes it will be like background app.
अरे नहीं हो रहा यार, इतना मेहनत लेके बनाया है, अब तो मुझे ही हो गया। पर बेसिकली वी प्रिपेयर्ड these certificates with name and designation, and for office bearers and past presidents it is with the photo. So I will be emailing them individually these certificates, and it is my honor to acknowledge your work and for accepting that token of love and appreciation and that certificate. So thank you so much.
Thank you, Dr. Lakshmi. We all are honored to receive this certificate. And as ICOG chair, you have been wonderful, and especially this Seed to Bloom series of ISOPARO. I think I had gone through all the episodes, and really you have done it very well with all international speakers, and very well done. Congratulations.
थैंक यू। सुलेखा मैडम, जो आप बोल रहे हैं ना, तो आई विल जस्ट टेक ब्रेक फॉर 2
अपना
months।
बना लेना।
आप जब अभी आइसोपाप का नया बॉडी इंस्टॉल हो जाएगा ना, तो सुप्रिया, we will take this as a vice president elect का activity, and I will be continuing Seed to Bloom as a vice president elect. So it will be directly national ISOPAP activity then.
Sure.
So we will continue.
Yes.
Okay.
And from March onwards, we will be doing it under the banner of national ISOPAP directly.
मैडम स्नेहा मैडम भी आ गई हैं।
हाँ, स्नेहा का तो मैंने स्पेशल बनाया है भाई। शी इज फाउंडर प्रेसिडेंट ऑफ विदर्भ आइसोपाप। शी इज द पर्सन हु ब्रॉट मी टू द आइसोपाप। How can I forget Sneha? Sneha, I would like to show your certificate. Just a minute. Today this thing is.
बट आपने पहला वाले को दिखाया, मतलब इट केम।
स्नेहा का नहीं दिखाया ना मैंने। रुको।
नहीं, मतलब बड़ा कर देना था मैडम,
अरे
बड़ा
नहीं,
होने से।
ये सब स्टैम्प में ही हो रहा है, पता नहीं जेपीजी का मैं शेयर नहीं कर पा रही हूँ। पर स्नेहा छोटा छोटा दिख रहा है, ये स्नेहा का है। बड़े में दिखा? Sneha, with your designation, we have prepared founder president of Vidarbha chapter Maharashtra. So दिख रहा है कि नहीं दिख रहा है? I don't know.
बड़ा नहीं दिख रहा है मैडम।
हाँ, बड़ा नहीं
बट
दिख रहा
उस
है।
वक्त दिखा था।
हाँ,
उस वक्त दिखा
तो
था।
I will be emailing you, Sneha. So I have tried not to forget anyone.
एक बार वो नेशनल को डालेंगे मैडम।
Thank you so much, Lakshmi. In fact, that is an honor for me, and we are very happy and proud to have you as patron for the Vidarbha ISOPAP, and of course the president later on. Thank you so much.
Thank you, dear. Yes, madam. सुलेखा मैडम।
आप चलो आप।
यस मैडम, बिल्कुल चलेंगे, और हम इसको मार्च से फिर सीधा उसको नेशनल आइसोपाप में कंटिन्यू करते हैं ये एक्टिविटी।
Okay. February में we'll meet there.
यस बिल्कुल AICOG में आ रही हो ना?
Okay.
बिल्कुल मिलते हैं।
I'm coming.
थैंक यू सो मच। थैंक यू।
From Vijayawada Society, we all invite you to come down to Vijayawada.
नहीं, I will come. I will just see the workout. I saw that there is a flight connection to Vijayawada actually. So Friday I can come. Saiti, you can stop the recording. I can come on Friday and I can leave on Sunday. So I will come.
Yes, madam. The other day I called you.
Yeah.
You said there is some clash with the some other conference.
अपना महाराष्ट्र स्टेट एमॉक्स हमारा सेम डेट्स पे है चंद्रपुर।
Yeah.
But I will see. There are flights, one-stop flights to Vijayawada.
मैडम अपना
Please
वो
come,
भी है।
ma'am. All of you,
Yeah,
please
we all
come.
will come.
Vijayawada for the national conference. Please register, ma'am.
अच्छा, रंजना आपका भी
Yes, Dr.
Thank you, Lakshmi ma'am.
रंजना
Thank you,
आपका भी है,
ma'am.
ईमेल करूंगी मैं। हाँ
जी ma'am, जी thank you very much ma'am. Thank you for remembering always and for the award.
Good
Thank
evening,
you ma'am.
everybody. Dr. Lata,
Thank
you.
Surekha ma'am.
Thank you, all of you.
Thank you.
Thank you.
Bye.
So much.
Bye.
Good evening. Bye. Good night.
Thank you. Bye. Bye everyone. Thank you,
Bye.
Lakshmi ma'am. Thank
Bye,
you.
everyone.
Lakshmi ma'am बहुत मेहनत की है. Thank you so much for this
नहीं,
episode especially.
सुप्रिया के बिना कुछ पॉसिबल नहीं था। I said you are backbone.
No, that I have to help you, but then you really worked hard for this episode.